Okay, we are back with the second half of our day. The next presentation is going to be by Dr. Crombleholme from Children's Hospital of Colorado. He's a fetal and pediatric surgeon. So he's going to talk to us more about the surgeries, procedures that go along with the CDH diagnosis. And I'm going to turn it over to him now. If you have questions, again, let's save them for the end. Jot them down online. Go ahead and put those into your window, and we will get those submitted and answered at the end. So I will turn it over to you, Dr. Crombleholme. You're welcome.
Well, thank you. It's a privilege for me to be here, and I just want to say thank you for the work that you do advocating for diaphragmatic hernia. I'm a pediatric surgeon, and just to give you a little background on how I got into this, I did my training at UCSF with Mike Harrison and was involved with the first open fetal surgeries done for diaphragmatic hernia back in the 80s. And diaphragmatic hernia has been a big part of my career. I spent 7 years at UCSF, 8 years at CHOP, and 8 years at Cincinnati Children's, and now come to Denver. And during that time, probably personally cared for somewhere between 350 and 400 diaphragmatic hernias in my career. And it's been a very major focus, both from a research point of view and a clinical point of view. And much of what I'm going to say today, I'm sure, probably sounds like preaching to the choir, because you probably get diaphragmatic hernia in a way that a lot of people, even in medicine, don't. But what I thought I could do is kind of give you a broad overview of the kind of things that we're doing now, the way we're approaching this from both a prenatal diagnosis, prenatal treatment, and postnatal treatment perspective, and where kind of the horizons are, where we're pushing the boundaries, and you know, what is going to be right around the corner in terms of what's coming next. So again, for this audience, this is probably all obvious, but diaphragmatic hernia is a very common phenomenon. About 1 in 3,000 live births, and the vast majority, 90%, are left-sided. The rest are right, and a very small percentage are actually bilateral. And about 2% are actually familial, where literally half the offspring of a couple can have diaphragmatic hernia. It is an autosomal dominant inheritance pattern. It's typically found on a routine ultrasound when it hadn't been expected. Sometimes mom is a little bit bigger because of polyhydramnios and obstruction of the stomach. Sometimes that's a presenting sign. And one of the things that I think is really striking is that if you look at the CDH registry, which is about 50 centers all over North America and Europe, only half of those cases are prenatally diagnosed. But if you look at fetal care centers around the country, over 90% of their patients are identified prenatally. Their postnatal care can be planned before the baby even arrives, and which can make a huge impact on the entire family, not just the care of the baby. Now, the evaluation of these babies has really evolved, and time was you just got an ultrasound and the diagnosis was made and that was about it. Well, it's really gotten much more sophisticated now, between measurements that we can do with ultrasound, fetal echocardiographic assessment of the fetal heart and how the diaphragm has impacted the heart, as well as fetal MRI to assess the severity of the diaphragmatic hernia, the impact on the development of the lungs, and what implications that has for the baby after delivery. So the pathophysiology, again, preaching to the choir, but a very simple defect in the diaphragm results in herniation of the intestines and often the liver into the chest, compressing the lungs, preventing the normal development that ordinarily occurs. And essentially it's like a pruning. So if you think of a tree with all the branches, if the lungs are compressed during these early stages of lung development, those branches just don't occur. And along with the airway branches not happening, so too the pulmonary vasculature does not have those same branches. And for reasons that aren't entirely clear, they become even more muscularized, those pulmonary vessels. And so there's a very reactive component to the pulmonary vasculature that can cause acute pulmonary hypertensive crises in the first few days after delivery. So the diagnosis obviously is made by ultrasound, and as you can see here, what we're looking at are ultrasound images of two diaphragms. And on your left is a baby the chest is up here and the abdomen is here. The stomach is herniated up into the chest, but the whole liver is down in the abdomen. And if you do nothing else, that's a favorable prognostic sign. And it's really encouraging when we see that. But if you have a baby like this, where literally half the liver is filling the chest, you know that that's a much more high-risk situation. And MRI has been very helpful. Sometimes it's hard to distinguish liver from lung or bowel, and it's been very helpful in diagnosing both the presence of liver herniation and its severity. Now, many, many years ago, back at UCSF, Andrea Metcalf was the one who proposed the lung-head circumference ratio. So that's probably familiar to everybody here, had that done as a prognostic variable. But we've definitely moved beyond just that, and we're now looking at using fetal MRI. So these are images of the baby, and we can calculate exactly what the entire thoracic volume should be in this specific baby. Not just looking at tables and nomograms and saying, well, it's in this range. We can actually measure that on this particular baby. We can separate out the mediastinum, where the heart and the great vessels live, subtract that, and then we have the lung volume that this baby should have if they didn't have diaphragmatic hernia. And then we can calculate the actual lung volume of these small lungs. You can see how small this left lung is in green here, and even this right lung is small, even though it's elongated, it's compressed. And that will give us the percent predicted lung volume, or PPLV. And we have a lot of experience now demonstrating how useful that can be in predicting the severity of diaphragmatic hernia. Another thing that we've learned, and it probably is just makes sense, but these are the lung volumes, total lung volumes of babies, normal babies, as a function of gestational age, going from about 20 weeks to 35 weeks. And what you can see is that there's a progressive increase. And this increase is the lungs growing, developing like they normally should. Well, if you're down in this range at 35 weeks gestation, that has significant implications. And that's exactly what can happen when the chest is filled by bowel and liver. And so we started looking at total lung volume late in gestation at 34 weeks and calculating that using MR. And what we can find is that there are absolute lung volumes that will tell us how serious this is going to be. So if we have total lung volumes at 34 weeks of more than 40 cc's, 40 milliliters, you see that we're at 90% survival, and only 10% of those babies required ECMO support. But if our lung volumes are much smaller, half that, less than 20 cc's, the survival drops to 35%, and we have an 86% requirement for ECMO support. So there are a lot of current predictors that are used in diaphragmatic hernia, but the problem with all of them is that all we're measuring is the size of the lungs. We're not really able to measure the function of these lungs, and we haven't up until now been able to predict the pulmonary hypertension and how severe that will be. So one of my fellows working with me, Fernando Valentin Solis, looked at the use of MRI to calculate what's called the Magoon index. And what that is we actually, on the MRI machine, measure the branch pulmonary arteries, the right and left arteries, add them together, and divide by the aorta. Now, you probably remember your high school biology. So the heart's in the middle. Here's the pulmonary artery coming off the right ventricle, and here's going to be the right branch, the left branch. And so we measure those diameters using MR, add them together, and divide by the diameter of the aorta at the level of the diaphragm. And what we've been able to show is that will predict which babies will have severe pulmonary hypertension, not when they're born, when they're 3 weeks of age, which is really the subset of diaphragmatic hernias that are really refractory. Virtually all diaphragmatic hernias have suprasystemic pulmonary pressures when they're born, and gradually that falls. And the more severe cases, the longer it takes to fall. So the very severest cases won't fall even out to 3 weeks of age. And that's what we were able to find, that even at mid-gestation, 23 to 25 weeks gestation, we can now look at the MRI and predict which baby is going to have profound pulmonary hypertension and may be a candidate for being far more aggressive with the management of that pulmonary hypertension after the baby's born. And so when you consider all the prognostic variables that have ever been reported, there's a huge list now. And it grows all the time, but we're talking about the impact of karyotype, liver position, LHR, observed to expected LHR, PPLV, total lung volume, modified immune index, the PPHI, or prenatal pulmonary hypertension index, another one. Well, sometimes these things don't jive. So you get good values with one thing, not so good with another thing. So we worked with biostatisticians to try to come up with a mechanism that would gel all of these things, that could put all of the data together in a coherent way and a relative weight to all of these things. And that's where we came up with this prognostic index. And it's basically a 10-point scale that integrates everything we know about prognostic variables in diaphragmatic hernia. And even though this looks complicated, it's actually very simple. Are there any genetic factors, whether it's karyotype abnormality or syndromes? Are there cardiac effects? Are there associated congenital heart disease? Is there LV-RV discordance because of compression of the heart? And the modified Lagoon index. And then the hernia itself, if there's a sac present, we know those babies do better. If the liver position is down, we know those babies do better. And then the lung itself, looking at lung to head circumference ratio, PPLV, total lung volume. And if you integrate all of these things, you come up with a 10-point scale. And you get a 1 point for deduction for everything that's abnormal. And what you find is that basically you have a stepwise fashion, 100, 90, 80. And then as you get down to 7 and certainly below 6, the severity gets really apparent. And so it allows you to more precisely be able to advise moms and dads about what we're dealing with. How serious is this? What end of the spectrum are we dealing with? And potentially consider alternate treatments if we know that we're dealing with the most severe cases. Now, I mentioned that this has been one of the most important aspects of my professional career, and probably the biggest thing I've learned in doing this for 20 years is the importance of having a team that works together and takes care of diaphragms exclusively. One of the things we learned a long time ago is that if you're even at a wonderful children's hospital, and they may see 5 or 6 diaphragmatic hernias a year, if they may have a staff of 20 neonatologists, 10 surgeons, and any individual may only see a diaphragm every couple of years, it's virtually impossible to get really good at taking care of these very complex babies unless you do it all the time. And so we, like Jason and John Kinsella here, formed a team of these folks. And it's not just the physicians. It's crucial to have the nurses on board, the fellows, have the patients cohorted together. Respiratory therapy is crucial. Nutrition, pharmacy, all of these aspects are vitally important. Because if even one of them is really not quite up to speed or not really familiar with caring for diaphragmatic hernia, it's going to compromise the overall outcome. When I travel around the country and I go to children's hospitals that don't approach it this way, oftentimes they will present the diaphragms that they've seen over the past several years, and they'll do case conferences and present them. And it pains me to say, but oftentimes there will be cases that you know in a different environment those babies would have survived. because the approach was not this approach. And not that there's just one way to do things. I don't mean to imply that. What I'm suggesting is that having a dedicated team that takes care of these babies is really vitally important. The other aspect of this team is that we can vertically integrate the care, and it's the way we do this in Colorado Field Care Center here. It's the same group of doctors from the time the baby is diagnosed prenatally through the nursery and then long-term follow-up. And we do the same comprehensive evaluation. We have agreed upon protocols for care in the NICU as well as their follow-up. And part of this, and most centers around the country have adopted variations of this, are principles of trying to do no harm when it comes to the lungs. Not beating up the lungs, making them do something they're not prepared to do because they're so hypoplastic. And in general, we refer to this as gentilation. And I think that's become a tenet of management virtually throughout the country. Another aspect of this that we've gotten very aggressive about, and fortunately have new tools to throw at this, is the management of the pulmonary hypertension. You probably have all heard about the honeymoon in diaphragmatic pregnancy. And all the honeymoon is that period before there's an acute pulmonary hypertensive crisis. The end of the honeymoon is a pulmonary hypertensive crisis. And we now have better tools to not only blunt that acute pulmonary hypertensive crisis, especially in the first few days after life, but prevent it from happening. And so the things that we're using now are inhaled nitric oxide, inhaled prostacyclin, even inhaled prostaglandin. And what these things have done for us is literally been able to either prevent the loss of the honeymoon, prolong the honeymoon period, if you will, but certainly blunt these acute pulmonary hypertensive crises that I'm sure many people in this room know, starting an IV, having a little mucus plug, even the most trivial stress, noise, can precipitate one of those crises. And it's that muscularization in the pulmonary vascular bed that causes this acute pulmonary hypertensive crisis. And I just show this was my experience in Cincinnati where I was up until last year, to show you the impact of having a team like this can have. So this was the pre-CDH team. This was before I arrived in 96 to 98. And these were the survival rates, just over 50%, and over 65% ended up on ECMO. In 1999, the CDH team was formed. And it was to their credit that John Fredrickson, who was a colleague of mine in Cincinnati Children's, recognized that, look, we're only seeing 5 or 6 of these babies a year. There's no way we can get good at it unless we concentrate the experience of a small group of clinicians. And they had a significant impact. You know, they got the survival over 70%, and they dropped the need for ECMO to 35%. I arrived in 2003, and we started the CDH team. And the impact of that is that we went from, in this era, seeing about 5 diaphragms a year to seeing between 25 and 30 diaphragms a year. And having the same group of physicians with that breadth of experience, we were able to do a lot of innovative things. One was the institution of different modes of ventilation, like bivent, introduction of very aggressive pulmonary hypertensive management using inhaled Flolan and other modalities. And we were able to drop the need for ECMO down to actually 10% if you exclude the exit to ECMO cases that we were doing for the most severely affected babies. And the survival was over 85%. And it was 85% despite the fact that we were seeing much sicker babies. So what happened was that we saw an increase in significant liver herniation from 33% back here to 56% here, and the need for patch repairs doubled. Those are both markers for severity. So despite the fact that the babies were sicker, and we joke that we were borrowing misery from other states because frequently we'd have families coming from all over the country, we were getting better results. And I think that's a tribute to the team working together and being able to innovate. And obviously, there are significant long-term morbidities that have to be dealt with in a systematic fashion to optimize every one of these children. And I have to say, you know, there's never been a better time, not that there's ever a good time, to have diaphragmatic hernia than now. Our results are better than they have ever been before, and we're making progress every year. But there's still a small subset that we're just getting nowhere with. And it's probably no bigger than 5 to 10%. And by the time these babies are born, their lungs are too small. Even if we support them with ECMO, we really can't get those babies out. And really the only alternative that we can come up with is that we have to intervene before they're born, help these lungs develop, or change the way we're supporting them. And so what I'd like to talk to you about now is fetal intervention. And one of the things that's been known literally for decades is that, at least by the physiologists, is that if you tie off a fetal trachea, the lungs get huge. They just get massive. And that's because the lungs produce fluid and it exits the trachea. And if you block the trachea, that fluid just builds up, the pressure rises, and it drives lung development. It accelerates the lung development. Now, it's not normal lung development, but it's driving accelerated growth. And that is something that has been successfully applied in the treatment of diaphragmatic hernia. So back when I was one of Mike Harrison's fellows, one of the things we did was we did open fetal surgery to repair the diaphragm just like we would do in the newborn nursery. But there was one big problem. When you tilt the liver down, you kink off the ductus venosus. The ductus venosus is that portion in the liver that communicates between the umbilical cord and the baby's heart. So it literally cut off all the blood supply coming back from the placenta. And we couldn't do it. And it became a contraindication to doing open fetal surgery to repair the diaphragm. So the idea of ligating the trachea to allow these lungs to get bigger and gradually reduce that liver, so you're not going to kink off the ductus venosus, is where we went next. The idea being that if you could block the trachea, accelerate the lungs' growth, take the blockage out, and then have a baby that could be supported after birth. And I apologize for the intraoperative photos. Hopefully these won't be too gory. But this is a patient of mine. And just so you know, she's 13 now. So you know it has a good outcome. This is the cut edge of the uterus, the stippled edge of the uterus. This is her right shoulder, her left shoulder, and we made an incision in the neck right above the notch. And we've isolated the trachea, and here we're putting 2 big surgical clips across that to completely occlude the trachea. And by ultrasound, this is the effect. So here's the preoperative ultrasound. And just to orient you, this is the right chest wall. Here's the heart pressed against the right chest. And remember, the heart should be over here. But this is stomach, and this is liver, and this is bowel. And then 27 days later, the heart is back where it ought to be, and this is all lung, all lung. These are cross sections this way, sagittal, and here you're seeing the right lung, and here's the left lung. So these lungs are dramatically increased in size. Oops. And here you can see the effect on the LHR. These LHRs went up uniformly except this one baby here. And what we found at the time of delivery is that baby had a little leak where we applied the clip. And if you don't have complete tracheal occlusion, the lungs can't grow. So our neonatologist, Dr. Dean, would never forgive me if I handed him a baby with 2 big clips across the airway and said, well, go to it, just resuscitate that baby, Jason. And so there's something called an exit procedure or ex utero intrapartum treatment. And that was designed to optimize this circumstance. So we would exteriorize the uterus, we would open up the incision, take off those clips, do bronchoscopy and take a look at the trachea to make sure that the trachea hadn't been injured. And we would intubate the baby and give surfactant, because these babies had profound surfactant deficiency from the tracheal occlusion. And this is a comparison of a baby who had diaphragmatic hernia, unrepaired and untreated in utero. So this is day one of life. So it was on VV ECMO, has a nasogastric tube, and you can see the viscera herniated up, the stomach, the heart is over here. This baby is day one of life, had tracheal occlusion. So this right lung is down to L2 on this side, and the only thing left in the chest is this little wedge of liver right here. And these lungs are not being aggressively ventilated. This is on minimal ventilatory pressures. So there's no question we can get these lungs to grow. The question is, can we get them to grow and to function the way they should? Because we're accelerating growth in a way that isn't quite normal. So the results of that experience were that only about a third of those babies survived. Now, at the time, and this was in the 90s, only 10% of these babies survived with conventional therapy. So it was an improvement, but it was incremental at best. And Mike Harrison and Craig Albanese at UCSF started doing what they call Futendo, trying to do minimally invasive approaches, hoping that that would improve the outcomes. And it was kind of minimally, maximally invasive because they had to exteriorize the uterus, put in 5 different ports to actually do the procedure. And they had an NIH trial to study this, and fortunately the NIH approved a much less invasive approach, which is doing tracheal balloon occlusion. So this is a fetoscope, and this is a 3.3 millimeter fetoscope. You can see it out in high resolution here. Here's the light source and the lens, and this is a detachable balloon. This detachable balloon, when it's inflated, is only about 4 millimeters wide and about 7 millimeters long. It's very small. And it was designed to be used in intracranial interventional radiology for patients who have like AVMs in their brain, where you can block off the blood supply. And you can see the balloon inflated right here. So this could be put in through a single port, through the baby's mouth, into the windpipe, blow up the balloon in the trachea, and then pull it, and the balloon stays and the catheter comes out. So much, much less invasive than doing open fetal surgery or this Futendo approach with 5 different ports. And this is just an intraoperative view. Here's the balloon within the trachea. Here's the vocal cords. And there was an important study that came out in the New England Journal in 2003 where they randomized these patients. And the tracheal occlusion group did exactly what was hoped. They predicted a 75% survival, they got a 73% survival. But here's the crucial thing. The standard therapy in the neonatal nursery had a 77% survival. And this is probably the first real hard evidence that we have that if you're at a center that does a lot of this, they're going to have better results. And that was a very, very important conclusion. The other thing was that they probably included patients that never should have been treated. If you have an LHR of 1.4, certainly during this period back in the early 2000s, we were having close to 100% survival with babies with LHRs above 1. So they were looking at too favorable a group. But the Europeans really took this and took it to the next level. And Jan de Prest, who's in Leuven, Belgium, and had colleagues, Eduard Gradicos in Barcelona and Kypros Nicolaides in London, have reported now a series of 210 babies that they have treated with this fetoscopic approach. So here's a cartoon of the baby. Here's the fetoscope going into the baby's mouth, into the trachea, and the balloon is being released in the trachea tube included. They had a survival of 49%. Now that's not perfect, but it's certainly much better than the survival of 20% with conventional therapy, this very same group of babies. And they were very careful to isolate the very sickest babies with diaphragmatic hernia. And so there's now what's called a total trial that's underway, and we're collaborating with CHOP, Cincinnati, Maryland, and Texas to be the North American component of this total trial to look at tracheal occlusion in a critical way. And one of the obstacles was that, Americans always think we do things better than anybody else. And that was the response when the European data came out. They said, oh, we don't have 20% survival. We do much better than that. So when I was in Cincinnati, we, CHOP and Texas Children's, all terrific places, great CDH programs. We all pooled our data and parsed it the same way the Europeans were doing. And what we found was we were doing no better than they were. So when we had this observed to expected LHR less than 25%, which is the criteria the Europeans were using, we had a 27% survival rate. The best places in North America, we weren't doing a lick better than the Europeans. So this convinced us more than anything else that we needed to look at tracheal occlusion in a critical way, and can't really dismiss what the results coming out of Europe. So this is that collaborative effort, and there's a stepwise process. We're now waiting for FDA approval. The IDE has been submitted. The balloon is not made in the US and it's not approved in the US, and that's been the obstacle to offering this. And you have to have severe CDH with LHRs observed to expected less than 25th percentile. We put the balloon in between 27 and the end of the 29th week and remove it between 34 and 35 weeks. And the endpoint is survival. Now, this is an alternative that we've been pioneering. This was a patient of mine. This is the very first baby ever to undergo exit to ECMO. This is a baby with a very, very bad diaphragmatic hernia, had an LHR of 0.7, and also had a congenital heart defect. And you can see that here's the uterus right here, the baby's partially delivered, and we have the ECMO cannulas that have been inserted. And this was in the early 2000s, and this has now become an option for the same group of babies that might be candidates for tracheal occlusion, because the tracheal occlusion isn't really available. And the rationale is that one of the most stressful things we do to babies when they're born is ask their lungs to support them in a way that they can't yet. They're just too hypoplastic. And what the exit to ECMO does is eliminates that stressful period when the baby's hypoxic, hypercarbonic, hypotensive, and the neonatologists are doing the best they possibly can to support that baby, only to spend hours with a baby very, very sick and then go on to ECMO. And so that's the rationale for it. But obviously we're talking about maternal risks here as well. Deep general anesthesia to be able to preserve uteroplacental gas exchange, and they'll be committed to C-sections with subsequent deliveries. And so just to walk you through this, we have very rigid criteria, the same criteria, or even more rigid than the ones being used in the European total trial. The uterus is opened using a stapling device, so we make a little tiny hole to put our stapling device in, and that way the uterine, there's a lot of moms in the room, you probably remember how bloody a C-section can be, and there's virtually no bleeding with this kind of hysterotomy. And the baby is partially delivered. We give them a little injection of narcotic and atropine and vecuronium to supplement the transplacental passage of anesthetic agents. Always get the airway first, so we put in an endotracheal tube, and then we do a tiny little cut down to dissect out the vessels. Here's the carotid artery, and here are the cannulas in place, and then we very gradually start the ECMO flow before the baby's even delivered. And then here the baby is now being delivered but is on complete ECMO support. And as a result, we don't have to put the baby on a ventilator at high pressures or potentially harm the lungs, and the ECMO machine supports the baby. And very recently at a national meeting, we reported our series of exit to ECMOs, And what we found was that exit ECMO survival was 50%, and the non-exit arm of this study had a 25% survival. So it's certainly not definitive, and I would not say that this is a standard therapy or accepted therapy. This is a therapeutic innovation that we need to study further. But for patients who are in this small subset of the most severely affected, this may be a viable option. And so I think, just to sum up, we've definitely seen progressive improvements in survival, and I truly believe our results now are better than they have ever been. And there are babies surviving now 5-10 years ago never would have survived because of some of the advances that have been made. I think we've learned the importance of having a team that is devoted to the care of these babies, and the importance of that experience that comes from working as a team with a large volume of diaphragmatic hernias. Therapeutic innovations have had their impact. I think what we're doing here and in some other centers around the country, vertically integrating from the diagnosis as a fetus to following these babies long term. Inhaled Flolan and other means of controlling the pulmonary hypertension. I didn't talk much about very delayed surgery, but we're now waiting to repair the diaphragms until the pulmonary pressures have fallen to about 80% systemic. And it used to be that the surgeons would rush the babies to the operating room, get the viscera out of the chest, and all it did was make the babies sicker. And what we realize now is they're fine up there. The liver's fine, the bowels are there. They've been there the entire gestation. It didn't suddenly become an emergency when the baby was born. And I've waited as long as 56 days to repair a diaphragmatic hernia, and the lungs grow. So that's an important lesson. We're also getting away from using Gore-Tex patches to repair these defects because they are associated with infection, with recurrence. And I've been using the transverse abdominal muscle flap now for about 12 years, and I haven't had a single recurrence and not a single infection. And these babies have done very well with that. And as you just heard about, exit ECMO is something that may be an option in that very small subset of patients at the worst end of the spectrum, and the same with the total trial. It's called tracheal occlusion to accelerate lung growth, and this is going to be available in the States probably within the next 12 months. And we'll see if this can push the bar a little bit further, just the way we hope that can go. So I think I'll stop there and be happy to ask any questions you might have.
So you're coordinating now with CHOP. I'm asking because our first summit we had with CHOP, and they revealed just to us their new protocol, which was shortening the duration of the trach. Is that all? Shortening
the duration of
the time period for the
tracheal occlusion. It's all part of the same.
It is all.
It's all part of the same. So there's a coalition between, I think I may have left out Toronto. So Toronto, CHOP, Denver, Cincinnati, Texas Children's, and UCSF.
Okay.
We're all collaborating together. We're just waiting on the approval of the FDA to be able to start offering this. What's that?
I used to work for a
so you know the process really well. It can be tough. So as soon as that's approved, we're going to start entering patients. The Europeans are obviously already. Yes, we're all working together. Same protocol, same approach.
What's the expected timeline of the approval for the FDA?
Well, it's a little disingenuous, but once it's submitted, a 60-day clock begins, and they have to respond. But the response may be answer these questions, then they get another 60 days. So they can keep resetting the clock. So there's no guarantee. But the hope is, and where we are now, we did a lot of work with a company in Paris that makes this balloon, and they've been providing the FDA with data about the balloon, its shelf life, its biocompatibility, all the typical things that the FDA wants to know about And these balloons have been put in thousands of patients in neurointerventional cases. It's not like this is a brand new device that there's no clinical experience with. It's just not, this is an off-label use of that device. So the FDA wants to be very careful, which is appropriate.
What hospitals would you say have the best CDH teams that you can like recommend? It's across the country because we want to be able to direct people. Because we come in contact all the time with new families on Facebook and stuff, and we want to be able to say, okay, these are the hospitals you should look into.
Well, there are a lot of hospitals that do a very good job, and regionally, what the best regionally, what I would consider, and many of these places I know very well because I worked there and was part of them. Boston Children's, CHOP, Cincinnati Children's, Texas Children's Colorado, UCSF are probably the very cream of the crop in North America when it comes to caring for diaphragmatic.
So after the
Columbia, well, there's an issue with Columbia, and I'll tell you. And Charlie Stoller's wonderful, and he and I are friends. The outcomes in Columbia are a different subset of patients because Columbia won't accept a transfer if they can't get a PO2 above a certain level, and those patients end up at CHOP. So yes, they do a very fine job with diaphragmatic hernia in general, but I think, and when I ran the program in Cincinnati, we had a new faculty member, Jason Fisher, who trained at Columbia, and he would come to CDH rounds every day, and he would be shaking his head. We always had at least 7 diaphragms in house at any given time, and he was saying, I just can't understand. So your diaphragms here are so much sicker than anything we ever saw in Columbia, and I just don't get it. And then finally he came back and said, I finally figured out, New York City is like 9 million people, and their catchment area is pretty much just New York. So they're getting kind of the middle of the spectrum of severity of diaphragmatic hernias. And more regionalized centers, like CHOP, like Cincinnati, are getting patients from extended areas. And so the good cases are staying locally. The really bad cases are getting concentrated at those centers. So, and I'm not disparaging Columbia. It's a wonderful place. They have terrific outcomes. But it is a slice of the spectrum that's a little different than some of the other centers. That's all.
I thought Charles from Brad Rogers.
Yes, Brad's terrific.
UVA gets it all.
Mm-hmm.
They can't pick and choose. It's
Sure.
from West Virginia, everywhere. And when we delivered in '99, we had it could have been she ended up in DC Children's or depending on if there were too many on ECMO. Because ECMO is
Yeah, they're only in so many places.
And I personally recommend maybe 3-5 hospitals where I would go.
And I think, I was being very selective in terms of geographic distribution and what I would consider to be the cream of the crop. That isn't to say that there aren't other hospitals that are very, very good and have almost the same results that are dispersed around the country. So I'm not casting aspersions.
No, I know. I mean, they're probably about 25 I would consider if I had to.
I bet you're right. I bet you that's about right.
But they're probably not 200,000.
It's true.
I have a question. So here in Colorado, there's only one other facility that deals with CDH. Where do you know if they will work exclusive to the tracheal occlusion now here at Children?
We will be the only place. Like I said, there will only be those UCSF, Toronto, CHOP, Cincinnati, and Texas will be the only ones in the tracheal occlusion trial.
Okay.
But it's not available yet. Now there are balloons out there. There's some at UCSF and there's some at Texas Children's.
And there's even been one in Providence, of all places. And I'll just say, this was made by a company that was in the States. They haven't made a balloon in over 5 years. So these balloons have been sitting on a shelf for 5 years. And I'm not sure I would recommend that to a family, because I don't know that you can guarantee that it's going to work the way it should work. I know that UCSF is still offering it, and Texas Children is offering it until they're not. And I know they only have a couple in each center, so there is an option if you want to pursue it. They have, yeah. Ed Yang was one of my fellows at CHOP, and the problem, so for those of you who may not have heard, so there's a hydrogel that you can inject. It's got a lot of uses in medicine, but this one doctor in St. Louis is doing this for tracheal occlusion. And the problem is, even when we were working on it at CHOP in the lab, we never proved that it was occlusive, which is a key component to proving that it works. Because without complete tracheal occlusion, you don't get the biologic effect. And he's been offering this to patients. And really, he presented, we were at an international meeting in Japan, and there was a lot of blood on the podium by the time he got done presenting these cases, because the community just really let him have it. I mean, the medical community let him have it. And we really think it's not right. There's also another center in Florida that has a device that they're claiming can do tracheal occlusion. Again, really hasn't proven it's occlusive, hasn't gone about it in a critical way, and there's a lot of skepticism similar to that approach.
So it's just in St. Louis that they're doing
The gel, yeah, and the outcomes have not been good.
So let me ask you another question. We were actually offered, from another facility in Denver, offered a tracheal occlusion. Can you explain to me, so that if this is offered to other families in Colorado, we have a clear understanding of how they're going about that, what they're doing? We obviously did not have that done. We got a second opinion, and we're thankful we did. But I would like to know, so we can educate other people here in Colorado about what our options are tangible and what the honest, true medical knowledge is on that.
So I would say that they can't do it. And if they do it, you can probably sue them. The places I mentioned, UCSF and Texas, have an IDE from the FDA for that balloon that's no longer being manufactured. So that's been sanctioned by the FDA. I think they gave them 10 balloons. They allowed them to do 10 procedures, and that's it. There's no one else in the country who has access to those balloons. And so I don't know what was promised or said, but it's not right. They shouldn't be offering that kind of information.
Would you say that most CDH cases will not need fetal?
90% of them don't need it.
Yeah.
And that's why we've been so
We usually have
rigorous
babies.
about saying, you know, only the worst end of the spectrum should consider tracheal occlusion or exit ECMO or anything that along those lines, because it's still experimental, it's in therapeutic innovation. But, you know, literally 90% of diabetics don't qualify. They're not sick enough, and they shouldn't be exposed to that kind of intervention.
Well, we do have parents that sometimes think that that's the only way to save any of these children, and it's not. Because
Absolutely
of the
right.
very severe
Yep.
CDH that we know 3 weeks down the line are still going to be expensive.
Exactly.
Does anybody else have any other questions?
Can you just touch on for me, just clarify the Gore-Tex patch and what the option is to that, and long term?
Great.
If you could just.
I'd be happy to. So the defects are often really big, and you don't have enough diaphragm to sew to diaphragm, which is the ideal circumstance, because then that diaphragm grows with the baby. There's no foreign body. It's safer over the long run. So there have been a lot of materials, the most common of which is Gore-Tex, which is inelastic, it doesn't give. And you sew that into whatever rim of diaphragm is left, and then you sew it to the chest wall. And the problem is, as the baby grows, it pulls away. It doesn't give. It doesn't grow with the baby. And so if you look at the studies, the range is anywhere from 5 to 50%, depending upon the study, of recurrent hernia with these Gore-Tex patches. We did a prospective study of these transverse abdominis muscle flaps versus Gore-Tex, and the failure rate or the recurrence rate was 25% in the Gore-Tex, and it was 0 in the muscle flap. And what we're doing is we make an incision at the belly button level rather than underneath the rib cage. And if it's big enough that it requires a patch, what we do is, if you imagine the cut edge of the abdominal wall, there are 3 layers to that abdominal wall. And we just peel down the innermost layer. That's the transverse abdominis. And it's like, you know those old-fashioned garages that it had one piece that would just close? So it's like closing one of those garages. We just pull that flap down, and it's attached to the rib cage in the front, and we sew it to the back. And so it grows with the baby, so it's not going to get infected. It's perfused by antibiotics, like the rest of the body would be. And because it grows with the baby, it doesn't pull away, it doesn't fail. And we've yet to have a recurrence.
So where you've peeled away those layers, does that pose a risk for herniation in that lining that is now less than, or does it
It doesn't come back.
Okay.
Okay, so this portion of the abdomen will only have 2 layers instead of 3 layers, which the babies do absolutely fine with. What we see sometimes, and this is true both with the subcostal incision and the transversus approach, is that sometimes, you know, a year of age, the baby grunts or strains, it'll bulge out right here. And that's because there's a little bit of a laxity, a weakness of that musculature, and that goes away with time. In both cases, the subcostal and the transverse approach. Yes, sir.
Now with the patch, I know my son was born 7 weeks premature, and he didn't have enough muscle to use, so there was a patch used.
Yep.
Now I know because he was extremely tiny when he was born, and now he's growing very rapidly now that he feeds. How is that patch going to work? Like, is that at risk of, you know, like when do I need to worry about it? Or
But a lot depends on how much native diaphragm was there to sew to. Because what will happen is the forces from the Gore-Tex will be transmitted to that native diaphragm. The native diaphragm will continue to grow. It's really in the areas where this patch has to be sewn to the chest wall, where there's not the same give, and that could potentially pull away. The other thing is that sometimes these babies, as you may know, are at risk for kyphoscoliosis, and we think that Gore-Tex patch actually probably either worsens it or predisposes it to occur, because it's preventing the normal growth of the chest cavity as time goes on. But I want to emphasize that because a baby has a patch doesn't mean it's necessarily going to fail or recur, but it's always a possibility. And most failures, how old is your child?
10 weeks.
Most failures occur in the first 6 months.
Okay.
So, you know, you get out beyond that period, and chances are there's enough diaphragmatic tissue to grow on its own.
I've heard of a lot of herniations happening like around the 2-year.
What age range do you have data on?
We have data with the Gore-Tex, we have data going out about 10 years. And the vast majority occur in the first 6 months, and then it steeply drops off. Which isn't to say that at 10 years old it couldn't happen, but it becomes far less likely once you get beyond the first 6 months. And I think that probably is segregating those babies who have mostly just chest wall and not much diaphragm to sew to, as opposed to babies who have probably more chest wall and the diaphragm can accommodate and grow.
We've seen it in growth spurts, typical growth spurts that kids go through. And many of the reherniations we've seen with the children, most of the time they don't have any symptoms. They go to the doctor.
Somebody gets an x-ray because they got a URI.
Yeah.
And there it is up in the chest.
And they're like, and of course it puts the parents in panic.
Sure.
And the doctors are like, he's breathing on his own, or she's breathing on her own. This isn't the same as.
The first time around.
Yeah.
So as
Exactly
parents,
right.
should we be doing standard x-rays every 3 months, 6 months, or is it because there is no symptoms sometimes?
Well, sometimes there's no symptoms.
Yeah.
Other times they'll have vomiting or difficulty feeding or abdominal pain. And you're absolutely right, it's not like when they had the first hernia. It's much less of an ordeal getting that fixed. And I wouldn't necessarily recommend routine x-rays. I tend to get routine x-rays in the first year of life while the lungs are undergoing remodeling and compensatory lung growth to make sure that that process is happening. But I don't think routine x-rays are necessary. Yes, sir, I know you've had your hand up for the longest time, I'm sorry.
Sorry, Patrick.
Yeah.
Yeah.
So, you performed what's the proper term? Something
The transverse abdominis muscle flap.
on my child. Should I put reherniation behind the aorta?
I wish I could say yes, but I think it's almost yes.
Well, with your statistics that you have.
We've never had a recurrence. So I wouldn't, I'm old enough to say never say never.
Right.
But I can get that off of my mind.
I would not worry about it. I think the chances of that are small.
So if a child has a reherniation, can that method of repair be used to fix that?
As long as there hasn't been a subcostal incision.
And what does that mean?
So if the baby was repaired with an incision like this, that burns the bridge. Because the blood supply is originating from here.
We have some children that have had constant reherniations at the flap repair, which is taking a piece, this is
The
like
latissimus.
the muscle, and believe it or not, you think this is, they're told that when there's mobility, it doesn't.
So is that an effective way to repair a reherniation?
That's kind of the last ditch effort, and it's typically done in the setting where you have an infected vortex patch. When you first have to take out the vortex, clear the infection, and then reconstruct the diaphragm with a flap like that. And it works very, very well, but it's a big deal to do that.
There are very few surgeons that do it, and they're very, I think, they have half a dozen kids that do it.
So if my daughter's Gore-Tex patch reherniates, then most likely she would get Gore-Tex again.
Yes, that would be the simplest, safest option under those circumstances. The latissimus flap, the reason it's so important to go that route is the infection. Because if you put a Gore-Tex into an infected bed, even if you've treated with antibiotics, it's very high risk that it will get infected again. And whereas the flap is native muscle that's perfused, it's not going to get infected. And that's why it's worth going the extra level to do a more complex operation to make sure that infection doesn't come back.
I have a quick question for you.
Yes.
So my patch was, it's probably like, the A3 Buick right now, but no.
This is 1983.
Yeah, so we're not even sure what my patch was called. We're thinking it was called
Could have been like a Dacron.
Yes, it could have been. Yeah.
Do you know, I'm 29, do you know if that ever has to be replaced, or if that's, I also
No.
have scoliosis, so it has.
It may have affected the scoliosis, but it never has to be replaced.
Okay.
The one thing about the Dacron is it tends to have more adhesion formation, and bowel obstruction can be more of a risk. Now, that having been said, you may never have a problem with that ever. But there tends to be more adhesions formed with the Dacron than the Gore-Tex. It's one of the reasons that Gore-Tex kind of replaced Dacron. And even something called Duo Mesh, which is kind of got a silicone surface on one side, Gore-Tex on the other to minimize those adhesions. But no, it doesn't need to be replaced.
Because the lower lobe of my lung is also hypoplastic, so that doesn't form any kind of complications down the line?
No, more than, it's just a matter of, sometimes the severity of the hypoplasia from a compression, that portion of the lung doesn't undergo as much compensatory lung growth as the upper lobe or the contralateral lobe. But I'd be willing to bet that your pulmonary function tests are probably pretty close to normal despite that.
Thank you.
You're fine.
I know. I just gave a speech about not living in fear. And I know.
Hold on. Do we have any other questions? No? Well, thank you, Dr. Crombleholme.
Sure. Thanks for letting me.